You're in seeing a patient, trying to keep it casual, when you get to that lipid panel. Cholesterol, triglycerides, LDL, HDL, the numbers just start blending together. And you daydream about a magical, needlessly steam-powered, H.G. Wells-inspired world where understanding the interaction between all these lipid transporters is so simple, so Victorian. Let me take you there now. You see, plasma lipids are transported in complexes called lipoproteins, and you'll soon see that each of the transport vessels at our statin steampunk station will represent a different class. Metabolic disorders that involve elevations of any lipoprotein class are termed hyperlipoproteinemias, or hyperlipidemias. Just think of it as an excessive amount of lipoprotein traffic coming and going around a central liver base. In fact, throughout this chapter, we're going to represent the liver as a cool, steam-powered, pseudo-Victorian-era industrial port, like this one. As each sketch develops, we'll orient chylomicrons, VLDLs, LDLs, HDLs around this liver base, detailing where these transport molecules are produced, where they're metabolized, and most importantly, how each class of lipoprotein is affected by the different families of lipid-lowering agents. The first agents we'll encounter are the statins, a ragtag band of steampunk pirates wreaking havoc on the lipoprotein shipping routes. However, before we get into their clinical pharmacology, let's briefly outline normal lipoprotein production and metabolism. As we introduce each new lipid-lowering agent, we'll fit it into this initial framework, illustrating how each agent exerts its unique clinical effects by disrupting specific lipid metabolism pathways. Alright, let's begin at the intestine, the starting point of exogenous lipid metabolism. See the dock at the top of the sketch? Notice we've included some intestinal-themed steam pipes leading up to the platform, as well as a series of flags depicting the microvilli of the luminal brush border. Individual free fatty acids and cholesterol molecules are absorbed here at the intestinal cell, before being transported to the bloodstream. However, cholesterol and fatty acids are insoluble in plasma, so they first are assembled into lipoproteins before being sent off into the circulation. So think of this intestinal dock as your first packaging and shipping center for exogenous lipids. Let's focus on cholesterol first. In this chapter, cholesterol molecules will be represented by gold bars imprinted with their molecular structure. As you'll soon see, these cholesterol ingots are the main cargo getting transported throughout the circulatory shipping network. After being absorbed from the GI tract, free cholesterol is packaged into a lipoprotein called a chylomicron, represented by the hot air balloon here, ready to transport the cholesterol cargo into the circulation. However, cholesterol doesn't really fit very well, confined to the outer surface of the particle. By converting cholesterol to cholesterol esters first, more cholesterol can be packaged into the interior of the lipoproteins. It's kind of like these gold bars here, getting packed into these cholesterol ester chests, before being loaded onto the chylomicron hot air balloon. This vastly increases the capacity of lipoproteins, allowing for more efficient cholesterol transport through the bloodstream. That hot air balloon looks pretty full already, though. That's because the main component of chylomicrons isn't cholesterol, but triglycerides. Throughout this chapter, whenever we want to depict triglycerides, we'll sketch in these triglyceride trident-wielding passengers, wearing the cool Jules Verne-style diving helmets. Inside the intestinal cell, free fatty acids absorbed from the lumen combine with glycerol to form triglycerides. Triglycerides and, to a lesser degree, cholesterol are assembled into a chylomicron and sent into the lymphatic system, eventually reaching the systemic circulation. All lipoproteins, such as chylomicrons, VLDLs, LDLs, HDLs, have on their surface apolipoproteins. These surface proteins aid in the creation, metabolism, and reabsorption of these particles. Chylomicrons are covered in all kinds of apolipoproteins, specifically ApoA, B, C, and E subtypes. We've incorporated the letter E into the sail on these chylomicron hot air balloons to remind you of ApoA through E. Also, ApoE will play an important role when chylomicrons are taken up by the liver at the end of their journey. Before they get to the liver, however, they're responsible for dropping off a few triglycerides along the way. At extrahepatic tissues, an enzyme called lipoprotein lipase, or LPL, hydrolyzes triglycerides in chylomicrons to release free fatty acids. Just think of our chylomicron hot air balloon docking at this lipoport lighthouse, where our triglyceride passengers are able to disembark. LPL is attached to the luminal surface of capillaries in and around these extrahepatic tissues. Once free fatty acids disembark, they can be used for energy by hardened skeletal muscle, for example, or they can be turned back into triglycerides and stored in adipose tissue. Once depleted of their triglycerides, these chylomicron remnants reach the liver, where they're cleared from the circulation. Specifically, ApoE interacts with the LDL receptor, and the particle is taken up by receptor-mediated endocytosis. This is depicted on the liver station at the load L receptor, where a dock worker is latching on to that ApoE flag and reeling in this depleted hot air balloon. The cholesterol ester chests that remain are unloaded and taken inside the liver, where they will either be converted into bile acids or repackaged and sent into the circulation on cholesterol delivery vehicles. Now, the liver does not rely solely on the endocytosis of lipoproteins as its source of cholesterol. Hepatocytes can also synthesize their own cholesterol via a pathway involving the formation of mevalonic acid by HMG-CoA reductase. HMG-CoA reductase will be represented by this HMG crude ore reducer, responsible for the production of more cholesterol gold bars. The first intermediate made is mevalonic acid, or mevalonate, embodied by the evaluator inspecting the gold ingots as they pass by. This freshly synthesized mevalonate undergoes a few more conversions by various hepatic enzymes before turning it into our final product, cholesterol. If not used for the synthesis of bile acids, cholesterol can be repackaged for transport back into the circulation. So back into the cholesterol ester chest it goes. Cholesterol esters are repackaged into our next class of lipoprotein, very low density lipoproteins, or VLDLs. VLDLs are the main export vehicle from the liver, containing a core of mostly triglycerides, about 60% of total weight, as well as cholesterol esters. As the last cholesterol ester chest is loaded onto our very low density airship, recall that the core of triglycerides is represented by the trident-wielding passengers. Notice too the B-shaped anchor hanging from the side of our VLDL airship. It represents apolipoprotein B100. It's the most important apolipoprotein to know because it distinguishes the circulating particles colloquially termed bad cholesterol. These lipid-rich lipoproteins, VLDLs and LDLs, are responsible for conveying lipids into the artery wall, leading to the development of atherosclerosis. VLDLs normally function as the export vehicles for delivering triglycerides to peripheral tissues. Just like in the chylomicron pathway, VLDL triglycerides are hydrolyzed by lipoprotein lipase, yielding free fatty acids for storage in adipose tissue and for oxidation in tissues such as cardiac and skeletal muscle. Just think of our triglyceride passengers yet again disembarking the VLDL airship at the LPL lipoport lighthouse. Depletion of triglycerides produces remnants called intermediate density lipoproteins. Some of these IDLs head back to the liver while the rest undergo further removal of triglycerides by hepatic lipases, before turning into low-density lipoprotein or LDL. In order to simplify our scene, we're going to skip that whole IDL intermediate part and jump straight to LDLs. All you need to know is this. LDL particles are formed as VLDLs continually lose triglycerides through the action of lipoprotein lipase and other lipases. They become smaller and denser until they reach the LDL form, containing a higher proportion of cholesterol esters. So, as our very low density airship is depleted of its triglyceride passengers, its density increases and it's remodeled into the cholesterol ester rich LDL ship before resuming its travels. LDL then continues on its shipping route as the main source of cholesterol for all nucleated cells throughout the body. As these LDL ships stop at the various islands off in the distance, imagine LDLs swinging by, your adrenals, for example, and dropping off cholesterol for steroid hormone synthesis. Adrenal cells, like all nucleated cells, contain LDL receptors which grab onto that ApoB protein to endocytose the entire LDL particle. Cells don't have enough cholesterol, they upregulate these LDL receptors. Cells have too much cholesterol, then they downregulate these surface LDL receptors, and the LDL particle moves on to its next destination instead. Normally, about 70% of LDL is removed from the circulation by the liver. So back at the liver station, our LDL ship docks at the LDL receptor and gets reeled in by that load L receptor set of dock workers. Specifically, the LDL receptor grabs onto apolipoprotein B, embodied by that surface B anchor we discussed earlier. The particle is then taken up by receptor-mediated endocytosis. Remember that the surface apolipoprotein B distinguishes the so-called bad cholesterol particles. Small cholesterol-rich LDL particles that aren't picked up by the liver can penetrate the arterial endothelial layer, leading to atherosclerosis. Alright, it's time to introduce our last lipoprotein class, high-density lipoproteins, or HDLs. HDLs are high density because they contain mostly protein by weight, with only a small amount of triglyceride on board. In this chapter, HDLs are represented by these H.G. Wellsian submarines, the highest density of our lipoprotein transport vehicles, and the smallest, meaning that they don't have much room for carrying triglyceride passengers. Nascent HDL particles are secreted from cells in the liver and intestine. Hence, our new HDL submarine emerges from underneath our liver and intestinal stations. It's missing something though, right? I mean, it could be more steampunky? There we go. After a complicated process where these nascent HDLs require some shiny new surface components from all that VLDL and chylomicron lipolysis on the right, you've got yourself a maturing HDL particle. Looking good. Part of this maturation process includes extracting cholesterol from peripheral tissues as well. We've depicted this cholesterol extraction here as our deep-sea diver collects these gold cholesterol bars from the sea floor. You see, HDL acquires this cholesterol from the membranes of peripheral tissue cells in the form of free cholesterol. Before transport, however, it's converted into cholesterol ester form. That's why these free cholesterol ingots are being loaded into one of these cholesterol ester chests. The enzyme responsible for the conversion of free cholesterol into this esterified form is lecithin cholesterol acetyltransferase, or LCAT, highlighted by the load catch platform, aiding our cholesterol treasure hunter. Once LCAT generates cholesterol esters, now you've got yourself a mature HDL particle. This ability of HDL to remove cholesterol from peripheral tissues is the reason HDL is often called good cholesterol. In fact, it's important to remember that patients with low HDL levels, that is, women less than 50 and men less than 40, are at increased risk for cardiovascular disease. HDL is critical for reverse cholesterol transport and normal cholesterol homeostasis. It delivers cholesterol back to the liver, out of your circulation, in two ways. First, it loads cholesterol esters onto those ApoB-containing lipoproteins, VLDL and LDL, with the help of cholesterol ester transfer protein, depicted by the chest transfer apparatus helping our HDL submarine load chests onto our cholesterol-carrying LDL vessel. Once loaded onto the LDL, these cholesterol esters are ultimately delivered back to the liver, where depleted lipoproteins are endocytosed at the LDL receptor. Also, HDL can deliver cholesterol esters directly to the liver via the scavenger 1 receptor. Just think of these HDL submarines as scavengers scouring the tissues for cholesterol, delivering their plunder back to the liver station. Alright, as the rest of this sketch unfolds, we'll illustrate how statins interrupt these pathways of lipid metabolism, with an overall effect of lowering the levels of LDLs in the circulation. Lowering LDLs is the key here. When a patient comes in with what they call hypercholesterolemia, what they mean is too many of those cholesterol-laden LDLs floating around. Enter the statin steampunk pirates, wreaking havoc on the defenseless workers at the liver station. It turns out that statins have extensive first-pass metabolism, so most of their effects are here, at the liver. Statins, such as simvastatin, atorvastatin, and rosuvastatin, work by putting a halt to HMG-CoA reductase, the rate-limiting step in cholesterol synthesis by hepatocytes. Just think of this statin punk putting a halt to the OR reducer. This results in decreased mevalonate and decreased endogenous cholesterol production. Remember though, there are two ways that the liver obtains cholesterol: by synthesizing it, which won't be happening anytime soon, or by endocytosing lipoproteins at the LDL receptor. In response to decreased hepatic cholesterol synthesis, hepatocytes increase their surface expression of LDL receptors, resulting in increased uptake of circulating LDLs. Just think of this statin punk pirate here harassing the LDL dock workers so that they reel in more of those LDL ships. Remember, statins are your most powerful drugs for lowering LDL cholesterol, with reductions in the range of 30 to 63%. So let's emphasize those decreased LDL levels by sketching in a sinking LDL shipwreck. Besides their potent ability to decrease LDLs, however, some statins also have the ability to lower triglycerides. So as our statin punk pirate pillages the LDL ship, he kicks off one of our trident-wielding triglyceride passengers as well. Statin therapy may also have a modest effect on HDL levels. Usually there's a slight increase, but this effect is variable depending on the dose and type of statin used. For a little reminder, we've sketched in one of the HDL submarines here, raised out of the water, seized by the pirates. Remember though, statins are not the most effective medication for reducing serum triglyceride levels or raising HDL levels. These agents will be represented later at the end of this chapter. The most important effect you should keep in mind is that potent decrease in LDL cholesterol. Let's sketch in a big pile of gold cholesterol plunder, our symbol for treating hypercholesterolemia. Here's what we mean by hypercholesterolemia. When a patient comes to your office and asks you about his latest cholesterol results, the first lab value you'll show him is probably his total serum cholesterol. Total cholesterol means adding up all the cholesterol from the various lipid carriers in the circulation. Those cholesterol scavenging HDLs, the cholesterol-laden LDL transporters, and don't forget there's some esterified cholesterol on board those mostly triglyceride-loaded VLDLs. If this total level is elevated, usually over about 200, that hypercholesterolemia term gets thrown around. However, the discussion should focus on the specific cholesterol fractions, in other words, HDL versus LDL cholesterol. You want higher levels of those HDL cholesterol carriers that are responsible for clearing cholesterol from cells. It's the LDL cholesterol carriers that can sneak into arteries and cause atherosclerosis. The main effect of statins is to decrease the number of these LDLs. So when lifestyle modification is not enough, a statin is often added to reduce cholesterol. Here's the thing though. On the exam, a patient is going to come in with numerous cardiovascular risk factors. He's a smoker, he has hypertension, he's had an MI in the past, maybe his HDL is low. Not a good sign. We like HDL. But he has normal range LDLs and total cholesterol. Then they'll ask you, what's going to prevent future cardiac events in this patient? Now, we all know that statins are not the best choice for raising HDLs. We'll get to those agents at the end of the chapter. And you might feel compelled to choose an agent other than a statin that can help boost those HDL levels. Stop that. Put that prescription pad down. Drugs that raise HDL, such as niacin, are not associated with improved cardiac outcomes. In fact, it doesn't even matter which of the baseline lipid fractions are out of whack. Yes, statins mainly reduce LDLs, but statins are the most effective lipid-lowering medication for preventing future cardiovascular events. That's why we've included the angel here, a recurring symbol for improved survival in patients with cardiovascular disease. Specifically, this angel sits above our red coronary crown. The yellow interior should remind you of the atherosclerosis of the coronary arteries. Remember, statins are the only lipid-lowering drug consistently proven to reduce the risk of atherosclerotic heart disease. It has become standard of practice to initiate statin therapy immediately after acute coronary syndromes, regardless of lipid levels. So we've included a steampunk pirate here, wielding our symbol for acute MI, the old myocardial banjo with broken heartstrings. A history of MI is a clear sign that your patient has coronary artery disease, yes, and may benefit from statin therapy. However, there are numerous other concomitant disorders that put patients at high risk for cardiovascular events. In these situations, statin therapy can be used as secondary prevention to reduce the risk of cardiovascular events and mortality. This includes diabetes, usually when other risk factors exist, or if a patient has had diabetes for a long time. So we've made one of the statin punks celebrating their latest rampage by downing our recurring symbol for diabetes, a sugar-ridden candy jar. Statin therapy can also reduce risk of cardiovascular events in patients with signs of peripheral artery disease, hence our gunky peripheral artery pipe here. Similarly, in patients with a history of stroke or TIA, statin therapy has been shown to reduce long-term risk of further vascular events. Ischemic stroke is represented by a black stroke of paint on a painter's cap, this time worn by one of the statin punks decorating their newly confiscated vehicle. Notice that he's painting none other than our recurring teratogenic tarantula symbol. That's because statins are usually avoided in pregnancy or breastfeeding women. Though the actual teratogenic risk to the fetus is unclear, clinicians recommend discontinuing statin therapy before conception. Myopathy is the most common complication of statin use. This is the side effect to remember for the exam. At the top of his gold cholesterol plunder, notice that the victorious Pirate King holds a recurring symbol for myopathy, the old crispy chicken leg with a bite out of it. The onset of muscle symptoms is usually within weeks to months after the initiation of statin therapy. Statin myopathy usually presents as a proximal symmetrical muscle weakness and/or soreness, and patients may describe functional impairments such as difficulty raising their arms above their head, arising from a seated position, or climbing stairs. Some patients, but not all, will have elevations in serum CK. Just remember CK for crispy chicken. Our statin punk king also raises the victorious LFT flag because mild elevations in liver enzymes are common with statin use. Significant liver injury is rare and usually reversible with discontinuation of the drug. Before starting statin therapy, liver function tests are recommended, though routine monitoring of LFTs is not necessary unless patients become symptomatic. Alright, the last thing I want to mention before we wrap up this high seas steampunk adventure, cytochrome P450. With the exception of pravastatin, the statin drugs are metabolized by the cytochrome P450 system of the liver. Our recurring symbol for cytochrome metabolism is a CYP450 license plate attached to a chrome bumper. In this scene, it's incorporated into a pseudo-Victorian era tank, trying to fend off the statin punk invaders. Drugs that inhibit cytochrome metabolism can cause increased serum levels of statins, leading to an increased risk of developing myopathy. Alright, let's sum up this steampunk high seas adventure. Statins are your go-to agents for reducing serum LDL levels. They inhibit HMG-CoA reductase, causing the liver to upregulate LDL receptors and pull LDLs out of the circulation. Statins only have more modest effects on triglycerides and HDL. Under our guardian angel, remember that statins improve survival by preventing future cardiovascular events. That's why statin therapy is initiated in patients with cardiovascular risk factors, such as long-standing diabetes, MI, peripheral artery disease, and ischemic stroke. The main side effect to remember is myopathy, as depicted by the pirate's crispy chicken leg feast. Also, keep your eye out for that LFT flag, because elevations in liver enzymes are common, though usually reversible. Last thing, statins are metabolized by cytochrome P450. Any drug that affects cytochrome metabolism affects statin levels as well. Alright, on to our next sketch, where we'll meet two more agents responsible for decreasing LDLs. Steam-powered, of course.